Dr. Fischbein, if you'd like to take it away.
I will. So people listening, hi everybody. I guess you didn't record my bio though, so people won't know. People won't know who I am. So maybe you can add that at the end or something if you want, or stick it in later. Yeah, I was asked by a member of your organization, and I've been a supporter of ICAN going way back to my days, early days of practice in the late 80s, early 90s in Los Angeles. I'm now basically retired from clinical practice. I moved out of California. I live in southern Utah now, and I do the podcast with Bliss, Birthing Instincts podcast. I go around the world and I teach 2-day seminars on breech and twin skills. Included in that is a talk about informed consent and coercion. So I took a few notes from that. So I thought I'd go through those with you in a sort of a PowerPoint format first. And then I'm hoping that you'll submit in the chat questions for Aaron to do. And I'll try to move quickly because I know we only have about an hour. So I should just go ahead, Aaron?
Yes, go ahead.
Yeah, you keep your mic on just so I don't feel like I'm talking to nobody. You know, one of the things about Zoom that I like is that I get to see faces, except this kind of a Zoom, I only get to see Aaron's face. So I know that there's many of you in there, and I appreciate you taking the time, especially you East Coasters who are, you know, it's going to be late for you. So I am going to share my screen. And let me know if you can see that, Aaron.
Yes.
Okay. So, yeah, I put this together on the fly. I was in Idaho yesterday, finishing up teaching. I drove all the way home last night and this morning. So hopefully this will be what people want to hear. I know we have a bit of a mixed audience. Aaron says some of you are moms and dads and some of you are birth workers. So I've tried to keep it so it's interesting for both of you. But let's see what I said here. Oh, hang on. How do I do that? There we go. So the definition of informed consent, because these terms are often bandied about. And it's like when I was a resident, they would tell me, you go into room 6 and consent Mrs. Jones for a C-section. It's like, that's not how it works. Okay. No, I give information to Mrs. Jones. Mrs. Jones gives me consent. So informed consent, the definition technically is permission granted in the knowledge of the possible consequences, typically that which is given by a patient to a doctor, not the other way around, for treatment with full knowledge of the possible risks and benefits. Now, you'll notice one of the things I do with my PowerPoints is when something needs further elucidation, I often put it in a different color or a different tone or font or something like that. So can we possibly give full knowledge of the possible risks and benefits of any procedure or any thing that we want, any information we want to give to a patient? And my answer to that is no. That's why I call it a quandary. It's an informed consent quandary. And that's a state of perplexity or uncertainty over what to do in a difficult situation. And really, that's what we're in. I started this lecture back in like 2020. So it was Informed Consent Quandary 2020. Now we're in Informed Consent Quandary 2026, and nothing really has changed. We're still in just as much of a quandary as we were back then. The American Medical Association, which, by the way, is not an organization I have a lot of respect for, and I'll say that openly, but they do have a code of ethics, if you believe that, and it says that rational, informed patients should not be expected to act uniformly, even under similar circumstances, in agreeing to or refusing treatment. In other words, it's not reasonable to expect two people given the same information to come to the same conclusion. That's what we as practitioners should understand. So informed consent can be done. I've simplified it to 3 different ways. True informed consent is the full assessment of risks and benefits of all options. And my feeling is it's not possible. Not possible because we don't know all the risks, not possible because we don't have time. The way the system is set up, doctors do not have time to give all the risks. Yeah, I mean, if you've ever looked at a package insert on any medication, you know that it would take you 15, 20 minutes or longer even longer to read it. When we give lidocaine, when we're doing a repair, We don't tell people that they could probably die from the injection, yet that would be a risk that's in the package insert. So you give them the what I call selective or limiting consent to those risks and benefits which can reasonably be expected to occur. And that's reality. Unfortunately, what happens all too often with informed consent is what's called skewed informed consent, where bias is inserted to give selective risks and benefits in order to funnel a person down a specific path. And that's my real pet peeve of mine. We all have a bias. I'm very open about my bias, and anybody who listens to the podcast knows my bias. The problem is that many of my colleagues who are obstetricians or maternal fetal medicine specialists, they all have a bias, but they think that their bias is correct, and they don't assume that their bias is just something that pertains to them only. The American Medical Association goes on to say the patient's right of self-decision can be effectively exercised only if he or she possesses enough information to enable an informed choice. The patient should make his or her own determination about treatment. The physician has an ethical obligation to help the patient make choices from among the therapeutic alternatives, consistent with good medical practice. Informed consent is a basic policy in both ethics and law that physicians must honor. Now, if you think like I do, you know that every day in every doctor's office, in every hospital, there's a violation of medical ethics going on because they don't do this. So a couple of things with this, and again, I highlighted the words good medical practice because it's another quandary. What is a good medical practice and who decides? I'll give you an example. When I first moved to Ventura County, California, I was the only person doing laparoscopic surgery. So if a woman had an ectopic pregnancy, I would operate on her laparoscopically. The other doctors there all did open surgery. It's called a laparotomy. So I was outside the standard of care, but I would say that my care was better than their care. So, but if the hospital or the hospital medical executive committee or whatever, or the risk manager of the hospital decide what's good medical practice, then they're going to make it difficult for other options to come into play. So it's a setup for corruption. It's a setup for things. We're going to be talking about something like a VBAC ban as a good example of this sort of thing. So ethics and decision making, there are more dilemmas. So informed consent is obviously a principle we're supposed to follow, and we're supposed to follow it because we have an ethical code we're supposed to follow. And the ethical code in medicine was long been based on what's called beneficence. And beneficence is the long-standing foundational moral imperative of doing right. So for instance, my ethical obligation to my client is to give her the best possible information so she can make the best possible choice. But what if my ethics are conflicted? As a solo practitioner, I didn't find my ethics conflicted, but what if I'm an employee, a doctor that's employed by a health system? For example, say Southern California has Kaiser Permanente. Kaiser Permanente wants all their patients to be delivered by 41 weeks. But a lot of doctors know that it's okay for a woman to go past 41 weeks. So now they have to skew their counseling to serve their master rather than their client. And so they have faltered in their dedication to beneficence. So what doctors and politicians and lawyers often do is when something doesn't fit the way they practice, they change the definition. So what's happened with ethics now is they've changed it to professional responsibility ethics, which means that, for example, supporting home birth is now considered professionally irresponsible. And any physician who does, according to ACOG, is acting unethically. So guilty as charged. Fiduciary duty is another thing that people need to understand, that doctors and well, everybody who's got a profession is supposed to abide by fiduciary duty. What is that? Well, fiduciary duty is acting in good faith with regards to the interest of another. The legal duty of a fiduciary is to act in the best interest of the beneficiary. Sounds nice and sweet. And as a solo practitioner or a solo midwife, we can easily uphold our fiduciary duty. But my fiduciary duty to my patient when I work in a hospital, it might be different than the fiduciary duty of the chief financial officer. The chief financial of the officer of a hospital is not interested in specifically in your outcome other than avoiding a lawsuit. What the chief financial officer's fiduciary duty to is to the hospital, keeping it profitable, keeping its doors open, and to its shareholders. So what's the fiduciary duty of a chief financial officer to lower the C-section rate in a hospital? And the answer is, it's not. It's not in his fiduciary or her fiduciary duty to do that. That sounds unethical to us, but depends on the point of view that they're coming from. So you can see why I call this a quandary. However, the American College of OBGYN, another organization I think has lots of problems. And if you want to know more about why I think that, you can tune into the podcast periodically, you'll find out. But conflicts of interest should be resolved in accordance with the best interests of the patient, respecting a woman's autonomy to make healthcare decisions. So even they say that if there's a conflict between what the hospital wants to do and what the patient wants to do, we should respect a woman's autonomy. Sounds great, but every day we all know that that's violated. So a real life quantity. So I specifically tune this obviously to VBAC because it is ICAN and it is what is it now? Cesarean Awareness Month?
It is. April is Cesarean Awareness Month.
Yeah, there we go. Okay. So we're going to talk about VBAC versus repeat C-section. So this is just a little cartoon that I love because a friend of mine used to raise French bulldogs and they all got delivered by cesarean section. So, but what's the deal with VBAC and VBAC bans? Are VBAC bans still going on? And I think ultimately, yes, they are. They're not overt. Many hospitals will say, we don't ban VBAC, we just don't have any doctors here that will support VBAC, which is in essence what's called a de facto VBAC ban. So ACOG practice guidelines. Now, you can ask your physician, and I think I have a slide coming up that says, if you ask your physician if they follow ACOG guidelines, they're going to say, of course we do. Of course we follow ACOG guidelines. So ACOG guidelines say, with level A evidence, which is, by the way, quality scientific evidence, that most women should be offered a TOLAC, which is a trial of labor after cesarean. That epidurals are okay for a trial of labor and that misoprostol is contraindicated. We know there's a lot of other things about it, but this is based on best science, randomized trials and that sort of thing. Then we have level B evidence, which is based on retrospective review or meta-analysis. It's not quite as quality science. And it says that a TOLAC after 2 C-sections is reasonable. Now, how many people know that ACOG supports that? Because many of you probably have tried to get one to do a VBAC after 2 C-sections, and your doctor says, no, we can't support that. It's too dangerous. Well, ACOG supports it. VBAC attempting with twins is appropriate. Oh, I'm sorry.
Oh, I was just going to say, or they say it's against policy.
Or it's against policy.
Yeah.
By the way, yeah, I have a T-shirt that says policies are not laws.
Yeah.
Right. So VBAC with twins, which is very dear to my heart because I think myself as a specialist in breech and twins. External cephalic version for a breech to try to turn it is not contraindicated if you've had a previous cesarean section. Labor induction with Pitocin or Foley balloon or whatever, it remains an option, castor oil, not Cytotec, not misoprostol. And a trial of labor with an unknown scar. So if you come from a country where they can't get your records from or whatever else, but you had a term C-section, you can just assume it's a low transverse C-section, and that is good level B evidence. Then in 2017, they added a couple more. They added that previous classical cesarean section or previous transfundal myomectomy surgery where they take out a fibroid is not a candidate, but this is level B. And again, ultimately, what they recommend, what these things are guidelines. And just because you've had a classical C-section and just because you've had a myomectomy does not mean you cannot have a VBAC. It might mean they might advise against it, but that you can take that information and you can decide, okay, I hear you, but I want a VBAC anyway. So I always joke that these things are not rules or codes or tenets. It's kind of like the scene in Pirates of the Caribbean where they're talking about the code and somebody says, no, well, that's more like guidelines actually. So you don't have to follow them. And they recommend that you have continuous monitoring while you're in labor, which, by the way, the data doesn't support. But ACOG does things that, again, these start to border on what's called level C evidence, which is consensus opinion. And they still believe that continuous fetal heart rate monitoring makes sense. Yet there's paper after paper after paper that shows that after 50 years of using continuous fetal heart rate monitoring to supposedly decrease the rate of cerebral palsy or intrapartum death, it hasn't done anything good. As a matter of fact, there's no evidence of benefit and there's evidence of non-benefit, but they keep using it anyway. And level C evidence, which is based on consensus opinion. And again, this is consensus of, ACOG and maternal fetal medicine doctors who, kind of play the party line. So they say, after counseling, the ultimate decision belongs to the woman. Which, by the way, I find shocking that's only level C evidence. To me, that should be the first thing in level A evidence, but they call it level C evidence. And they say women attempting TOLAC should be cared for in a hospital. And a level 1 center means any hospital doing labor and delivery, which means any hospital that says we can't do VBAC because we are a small hospital is violating ACOG guidelines. And the last one is sort of obviously a bias against home birth. They don't want you doing VBACs at home, which many, many midwives know, and I've published data on that show the success. Not only is it as safe as hospital-based VBACs or TOLACs, but the outcomes and the success rates are much higher. So is VBAC high risk? And this gets, by the way, to the definition of what does high risk mean. So when your doctor talks about VBAC being high risk, they're going to tell you the risk of your uterus rupturing, which is a terrible word. What it should be called is scar dehiscence, where the scar separates. And that happens somewhere between 1 in 200 to 1 in 333 VBACs. Okay. Now, not all scar separations lead to a terrible outcome. What percentage do? Well, if you look at the literature, you find that between 5 to 16% of newborns will be severely injured. And by severely injured, that's a euphemism for terrible outcome. Okay. And so the actual risk, if you take the two higher numbers, the 1 in 200 and the 1 in 6, is actually 1 in 6 times 1 in 200 or 1 in 1,200. When you're counseling somebody ahead of the game, the risk of them having this terrible outcome is about 1 in 1,200. And if you take the lower numbers, it's actually 1 in 6,666. Okay. But we use 1 in 1,200. So what your doctor is telling you is that 1 in 1,200 is high risk because every woman who's going to do a trial of labor after cesarean is going to be labeled with the term high risk. So is 1 in 1,200 high risk? Well, that's the same as a woman who's just under age 25 having a baby with Down syndrome. Do we tell 24-year-old, 25-year-old women that they're at high risk of having a baby with Down syndrome? And the answer is, of course we don't. So we selectively decide what we think is high risk and we label it, and then other things we ignore. Okay? Rupture is not predictable, it is rare. High risk, so high risk is not a number. High risk is something that makes your doctor or your hospital system uncomfortable. Because many of the things that they offer you to avoid something that they consider high risk actually carries more risk. For example, they'll label a woman over 35 high risk. So they'll want to induce her at 39 weeks. Which one actually carries more risk? Being over 35 or being induced because you're over 35? The answer is the second one, but the first one is the one that carries the label. Mm-hmm. So you're getting the picture. I can't see your faces, so I hope you're all like getting nauseous and scratching your heads and like getting aggravated because it is aggravating. Okay. The misuse of language as coercion. So ACOG, this is just an example of why I'm not a big fan of ACOG. ACOG recommends the use of motivational interviewing when, hang on, my face is in the way. I can't read my whole thing here. Let me move this over here. Go. When patients are hesitant or resistant to a strong recommendation. So I won't ask you because I can't see your faces, but motivational interviewing is a euphemism for what word? Erin?
Coercion.
Yep, there you go. So they recommend coercion when patients are hesitant.
Yeah.
That's what they recommend. They call it this. They say motivational interviewing is a client-centered, wow, does that sound good? Counseling style for eliciting behavior change by helping clients to explore and resolve ambivalence toward the choice of practitioners they prefer. As an example of this, several years ago, this was just before COVID, so it was like 2019, I got an email from ACOG, and it was about DTaP shots for pregnant women. And they told us that if you counsel a woman to get a DTaP shot at 28 weeks and she declines, then the reason she declined was because you counseled them wrong. I'm pausing for effect here. Okay. Subtle coercion is still coercion. Does your obstetrician and hospital follow ACOG guidelines? The answer likely, as I said earlier, is yes. They're going to say they do. Okay. But it's not informed consent if you make me afraid to say no. So ask your doctors, and this is something that, this is the part of the talk where I want to get into what you can do when you feel like this doesn't sit well with you, what's happening to you. One of the things that ACOG put out was what's called ACOG guideline number 664, or ACOG committee opinion, I'm sorry. And it came out a decade ago already. And it says, on the basis of principles outlined in this committee opinion, ACOG makes the following recommendations. Now remember, your doctor says they follow ACOG guidelines. Your hospital labor and delivery ward probably says we follow ACOG guidelines. So do they follow these? Pregnancy is not an exception to the principle that a decisionally capable patient has the right to refuse treatment, even treatment needed to maintain life. Therefore, a decisionally capable pregnant woman's decision to refuse recommended medical or surgical intervention should be respected. How many of you knew that? How many of you know actually this one? Because this one blew me away when I first read it years ago. The use of coercion, this is ACOG now, is not only ethically impermissible, but also medically inadvisable because of the realities of prognostic uncertainty and the limitations of medical knowledge. As such, it is never, not sometimes, it is never acceptable for OBGYNs to attempt to influence patients toward a clinical decision using coercion. OBGYNs are discouraged in the strongest possible terms from the use of duress, manipulation, coercion, physical force, or threats, including threats to involve the courts or child protective services to motivate women toward a specific clinical decision. So what I would recommend to birth workers out there and to parents out there is, look this up, print it out, put it in your birth kit. I mean, put it in your birth bag. Just carry it with you. I think there's more, actually. I think that's the first. I cut it back because of time. So years ago, I think I have it coming up, but I wanted to get into that because if you're not supposed to use coercion of any kind, then there's this ethical question that I actually was lucky enough to attend the VBAC consensus statement at the NIH in 2010, and I got to ask the panel a question. After they had listed their data and put their data out there, they said that a successful VBAC carries less risk to the mother and the baby than an elective repeat cesarean section. That was their information. And they said that 70 to 80% of women who attempt a TOLAC will be successful. That was also a statement made by them. So my question to them was, therefore, hospitals that are prohibiting a TOLAC are forcing 70 to 80% of women to undergo a surgery that puts them and their babies at greater risk of injury. Are these women being given true informed consent? Are they being treated ethically? That's a rhetorical question. Of course they're not. And they didn't answer my question. They were very diplomatic about it, saying that that's what we're here to talk about. But based on the statements that they put out, it made it very clear that VBAC bans were unethical. Back to 664 says OBGYNs are encouraged to resolve differences by using a team approach that recognizes the patient in the context of her life and her beliefs and her values and her future fertility desires. Does she want more children? and to consider seeking advice from ethics consultants when the clinician or the patient feels that it would be helpful in conflict resolution. They also say the college opposes the use of coerced medical interventions for pregnant women, including the use of courts to mandate medical interventions. Now, we all saw, maybe you didn't. If you have a normal life, you probably didn't, but we all saw what happened in Florida a few weeks back, where this woman wanted to have a VBAC, I think, after 4 C-sections, and they, without her legal representation for her, they got a judge to zoom in with her and tell her she had to have a C-section. That violates every tenet of ACOG's ethical guidelines, and they did it anyway. It is not ethically defensible to evoke conscience. You don't want any harm to come to your baby, do you? As a justification to attempt to coerce a patient into accepting care she does not desire. And one more thing with the AMA, they say patients have the right to make decisions about the care the physician recommends and have those decisions respected. A patient who has decision-making capacity may accept or refuse any recommended medical intervention. So hopefully I beat that horse to death. And now everybody understands that as long as you're not in a coma or some other mental dilemma, they're supposed to honor your decision. Because self-determination is personal sovereignty. What about informed refusal? Just a brief mention on that. No is a complete sentence. You can say no, and you don't have to justify why you're saying no. You can just say no, I'm not doing that. No, I don't want vitamin K. No, I don't want hepatitis vaccine. No, I don't want continuous monitoring. No, I don't want an IV to start. I'll take one if you can explain to me during labor why it might be justified. But right now, I don't want one. And they have to comply with that. They'll tell you that they don't. They'll tell you it's their policy that they have to do this and that. And you can kindly say, I respect that you have a policy, but that's your policy. I'm not party to your policy. And they can't kick you out of the hospital because you're not complying with their policy. It's a violation of federal law. Patient's decision to decline recommended treatment after all options, risks, and benefits have been thoroughly explained is the definition of informed refusal. And the consent form, remember, isn't informed consent. You do not have to sign a consent form to get cared for. They're going to tell you you do. They're going to tell you we can't admit you to the hospital until you sign these forms. That's coercion. That's like saying, would it be a shame if your establishment burned down if you didn't pay me $300 a week? What's the difference? The consent form isn't informed consent. All right. And you don't have time to read it. And generally, when you're in labor, you're not in the right mind to read it anyway. Okay. And lastly, what about uninformed refusal? Just one word on that. The patients have a right on that too. They can just say, let me explain to you why I want to do this. No, I don't really want to know. I don't want it. And they're supposed to honor that. So this is the kind of thing where if you take notes from this, carry these things with you, but don't wait until you're in a situation where you need to be confronted. Check these things out ahead of time. You know, when you move to a new community, you check out the schools, you check out the parks, you check out the where's the Costco, you check out the, lots of things in the local community. But one thing we don't generally check out is the hospital in our community, but we should check that out before we need it. Just a hint. Okay, some things to know when under duress. You have the right to be informed of benefits, risk, and alternatives. We already talked about that. So everybody knows that you have that right, even when things are under duress. They can't say, well, this is an emergency now. You have to do what we say. You have the right to say, I want to be informed. Ask permission to video or record any conversations. For instance, you're in the hospital and your baby's breathing a little fast and they want to take the baby to the NICU. You can, and the NICU doctor comes down and wants to talk to you about why they want to go to the NICU. You ask permission to video what he's going to tell you or she's going to tell you. Anybody who's honest would be happy to have them be videoed. Hospitals will often put in a policy that says you can't video this, you can't video that. I'm not sure those things are legal. You have to check with your own state and hospital. But if they refuse to want you to video them, and you could say, listen, my father's a physician. He wants to hear your explanation, but he can't be here right now. So ask them. But if they don't let you video them, that's a big red flag. Why wouldn't they be willing to stand by what they're saying? Do not sign any consent form you disagree with. I already talked about that, so I won't go into that. You have the right to request an ethics consult or a meeting with the chaplain. So at any time when you feel like you're getting bullied or things are getting heated, it's very sad that it's gotten to that point, but you can say, time out. I want to talk to the ethics consultant. And every hospital has one. And their bylaws state they have to provide one for you. Now, the ethics consultant works for the hospital. So there is that fiduciary duty thing, again, we talked about earlier, but it is a way to slow things down, calm things down. The people that are giving you a hard time will have to leave the room. You'll have time to talk to the ethics consultant or the chaplain or rabbi or imam or whatever they have they're providing for you so that you can calm things down a little bit. Just things to know. You can fire your caregiver. Hospitals often the way hospitals work now is they have a shift mentality and they have somebody on you've never met before, and you may not get along with that person. And you can kindly say, listen, I know that you're probably really good at what you do, but we're not clicking. You're fired. I want somebody else. And the hospital can't say to you, well, he's the only person on call today, so you have to take him. They can't. They will have to find somebody else. You need to know your rights. The thing is, most people, when they go there, are already so scared, so fearful, because nothing makes you more scared than thinking there's something going to happen to your baby. And it's a very easy way to manipulate you. But that's why you need to know these things ahead of time. Comments such as your baby might die, your insurance won't pay if you leave against medical advice, or we will call Child Protective Services or law enforcement are never acceptable, as we've talked about already. Plan ahead. Ideally, have alternative caregivers you trust who are not part of the hospital system that can offer second opinions. Whether that's a family member, a friend, a doctor who's outside your insurance realm, who you might have to pay out of pocket because they're not in your network, but maybe has a better reputation in your community or with the midwives of your community, to have them available to come in and give you a second opinion or just give you one on the phone. Just thoughts. These are just ideas. Right? Sometimes this list can be very intimidating to people because they just want to go in and they just want to have their baby and they don't want to make waves. Problem that the hospital's fiduciary duty is not the same as yours. They put nice commercials out that say they want you to thrive and they want you to do well, but their outcomes belie that commercial. Because despite all the advances in so-called technology that we've had, and I use the word lightly, more ultrasounds, more fetal monitoring, more labor curves, more laboratories, more maternal fetal medicine specialists, more ultrasounds, more color flow Doppler, more epidurals, more NICU admissions, more postpartum hemorrhages. The outcomes are getting worse despite all this. So you have to take responsibility for your own family. And you can. Knowledge and trust are good communication and the keys to overcoming fear. Though knowledge, trust, and good communication are the keys to overcoming fear. Our patients have the absolute right to ethical treatment, informed consent, and informed refusal. This was a lovely couple that came down to Los Angeles from Oregon, believe it or not, because they couldn't find anybody there to support them in a VBAC. And they drove all the way down, they relocated, they spent a month down in Los Angeles. And this is from Anna. She says, I walked away from Miles's birth wiser, empowered, more in love with my husband and with myself, because she took things into her own hands. And she didn't accept the fact that her only option where she lived was a repeat C-section. When you talk, you're only repeating what you already know, but if you listen, you may learn something new. Okay. So I got that done in 38 minutes. I'm thrilled.
Good. We have plenty of time for questions. So if anyone has any questions, feel free to, we have, I think, both a Q&A or you can post them in the chat.
There's some in the chat, I think.
I think I just saw comments.
Oh, they're just comments. Okay.
Yeah. I'll start with a question. What about when you have skewed information? How does that relate? So a provider might be using old data for uterine rupture rates or something. How do you look for your own sources for data, or how do you kind of work with a provider that may have outdated or inaccurate information as part of their
Well,
informed consent?
there's the easy answer that if you know that this is outdated information, they're still using it, is to find a new provider. That would be the easy way out. But I will tell you that's a really good question, because data and science are very skewed these days. There's a lot of manipulation going on in the journals. Some things it's very hard to get published. Other things get published easily because they fit the narrative. Journals are usually sponsored by pharma. And if there's something there, and I'm not picking on just on pharma right now, but just science in general has been corrupted by money. Obviously, everything is corrupted by money. So it's very hard to know. But when you're looking at a scientific paper on obstetrics and gynecology or obstetrics, a couple things to know. First of all, they almost always use the same endpoint. And the endpoint is neonatal death and neonatal morbidity. That's the endpoint in pretty much every paper on obstetrical outcomes. The term breach trial, the ARRIVE trial for two well-known ones, but pretty much every paper. What they don't look at is, gee, how did that baby do at age 2? How did that mom do? How's that baby's microbiome? How was mom's breastfeeding rate? What was her postpartum depression rate? Did she feel traumatized by her birth? These are messy things, and doctors don't like messy things. Researchers don't like that. They like things they can quantify. They don't like subjective things. They like objective things. So if you're going to look at research, first of all, you have to consider the source. You have to look at the authors, where it came from, conflicts of interest. This is not something the average person wants to do. And you cannot just read the abstract or the conclusions. Most of us do that. It's kind of like we read the headline and then we don't read anything else, all right? Because we're used to Instagram. We're used to getting our news in a matter of like 6 seconds and then scrolling to the next thing. When you read a paper, you really need to read the boring part called the material and method section, because that will tell you how they've done the research. You know, was it retrospective? Was it prospective? Was it randomized? Was it blinded? How many people were how many cohorts were in the study? Are they making a conclusion based on 12 people? Or was it 5 rats? You know, or was there, 16,000 people in the study? Those kind of things are really important. And then you have to look at what they used for their outcomes. Because if you see the word, and this is something that I learned long ago, but if you want to look at morbidities, if you see the word composite morbidity, you need to be suspicious. Because composite morbidity is really a statistical trick. Because when we're looking at something for whether it does good or bad, we want to know, does it save us from a really bad outcome, like brain damage for a baby? Now, if you look at a study like the ARRIVE trial, and they look at outcomes, the ARRIVE trial was inducing all women at 39 weeks, and you look at outcomes, there aren't enough bad outcomes to suggest that inducing everyone at 39 weeks makes sense. But if you start to put in other outcomes and call it a composite outcome, the weirdest example I've ever seen is they included things like brain damaged baby and bruised scrotum or broken clavicle. Obviously, nobody likes to break a clavicle, but it is not in the same realm as a brain damaged or a dead baby. But they'll lump them together in order to reach a p-value that becomes statistically significant so they can publish their paper and say they had something statistically significant. It's a nasty business, academic research. Academicians are under a lot of pressure to publish and come up with stuff, and everybody puts their name on it. So when you have a physician who might be handing you the term breach trial, a 25-year-old study that was actually flawed and refuted within a couple of years, but it's still quoted by them, that is a doctor who you probably should run away from. If that doctor is approachable and you like that doctor, then you could make an appointment and sit down with them and say, why do you still put that out there? Why don't you look at all these other papers that support properly selected breech vaginal delivery with a skilled practitioner? Why are you saying that somebody with a teed a surgical incision, they had a low transverse incision, they had to extend it a little bit, they must have a repeat cesarean section? Why do you say that? What's the actual risk to me? You want to know actual risk, not relative risk. And that's actually, I didn't even say that before, but when you're looking for informed consent, don't let anybody consent you or give you information that's relative risk, like saying it's 3 times riskier. Because that means absolutely nothing if you don't know what the denominator is. For example, if something happened in California last year, it'd be 1 in 40 million. Actually, less now because people are leaving, but that's another story. But let's just say 1 in 40 million. Say this year it happened 10 times. Somebody could say, wow, this thing is happening there's a 10-fold increase in it. We need to put some research money into that. Yeah, but it's still 1 in 4 million. So this is the way they deal with stillbirth rates in twins, and they get you to be induced early with twins because they say the risk is twice as high or 3 times higher. Yeah, but it's still far less than 1/10 of 1%. But they don't know that. I can guarantee you that some of the statistics. Listen, I know what I know, and I'm not afraid to admit that I don't know stuff. I think confident people are really comfortable admitting they don't know stuff. I think it's the insecure person who feels like they have to throw out data that they pulled out of their rear end. So, but how are you as a patient supposed to know that unless you do your research ahead of time? So don't show up in labor not knowing anything. Don't get when you're pregnant or even before you decide to get pregnant, do your research. There's so much information out there. There's so many good podcasters and so many good Substack writers and so many good things where you can find information outside of the mainstream. You can look at the CDC and you can look at ACOG's guidelines and stuff like that, but you have to remember who's writing them.
Yeah, you have to
Who's
find
sponsoring ACOG and who's sponsoring the CDC. And for the most part, it's big pharma and big hospitals and big insurance.
Yeah. We have some more questions. So what should the members of the military community do when they are lower on enlisted, I believe that is, and feel like they are outranked, either themselves or their husband?
Yeah, well, that one I can't answer because the military is a different animal.
Yeah.
I mean, when you sign up for the military, you sign up for the military and you follow the Code of Military Justice. I think that's what it's called. Uniform Code of Military Justice. And you follow rank. And if you're ranking off, I mean, again, ranking officers shouldn't be able to trump your ethical obligation or ethical right to informed consent. But if they do, they do. And if that's the only thing you can afford, I don't know. If you're an enlisted person, can you pay for a private doctor and go to a private hospital? I don't know. I mean, most probably on your salary, you can't afford it, but that's something you should consider. And then one of the things I would just say to everybody listening is put money aside in a health savings account when you're young. If you have teenage daughters, sons too, but if you have teenage daughters, start a health savings account for them. So that the day comes when they may have irregular periods, they may have a problem, and their only choice is to go to some doctor in an HMO. No, they can pay to go see a NAPRO doctor or a naturopath, and they pay out of pocket, and they can go to see them, or they can pay for a home birth midwife because they can afford it, because you should value that. We should value our health, and we should the pregnancy and the birth of our children, because the birth of your child is the thing you'll remember till the day you die. And so many of our women don't have good memories of their birth. They obviously love their baby, but there are many, many women who don't even remember the birth of their baby because they were knocked out or their baby was taken from them immediately and they don't remember anything after. My mother, I'll just say something very personal. My mother did not remember my birth because she was given twilight sleep and I was pulled out with forceps. And then I was taken to a nursery. And do I know anything a lot about pre and perinatal psychology? No, I don't. But I could tell you, I had issues with my mom my whole life. And I don't know. Did it start because we never bonded? Don't know.
Yeah.
It's hard. I've gotten to the point in life where I feel comfortable sharing that story because it does, how we come into the world matters. So the military is a different animal though, guys. I don't know enough to answer that question. I have done, by the way, I have done 3 home births on military bases. You have to go through clearance and all that stuff during the pregnancy. And then when they're in labor, you go through the gate and you go in and you do a home birth. And it was kind of fun for me to do it on a base. So you might have that option to have a home birth on your base.
Yeah. So going back to anesthesia, what is your opinion on hospitals who say they can't support VBAC because they don't have anesthesia on call 24/7?
Well, the guidelines don't say that. First of all, the guidelines went back to they got rid of immediately available, readily available is the standard. But that's ridiculous. And why that's ridiculous is because 99% of emergency sections have nothing to do with previous cesarean section. They're for fetal bradycardia or prolapse cord or abruption of the placenta, and they somehow seem to manage those. So it's a lie. And the other thing that's also a misconception is that being in the hospital is necessarily safer. And people ought to know that when you have a baby that's got a perfectly normal heart rate in labor, and suddenly there's a scar rupture and there's a placental abruption and the baby's heart rate goes way down, you probably have somewhere between 8 and 14 minutes, that's stretching it, to get that baby out before it suffers permanent asphyxic brain injury or worse. Very few hospitals, even quality hospitals like Cedars-Sinai where I trained, can get a woman who's laboring in a labor room who may not even be monitored. I mean, maybe monitored, but somebody doesn't notice for a couple minutes on the monitor out at the nursing station. Can they rush in, make a decision what's going on, take her back to the OR, get her on the operating table, happen to have an anesthesiologist immediately available, happen to have an OR crew immediately available, happen to have a surgeon and an assistant surgeon just happen to be standing by, and get that baby out in 8 to 14 minutes. It's a false sense of security. When ACOG says they don't VBAC at home, it's because because they think that we can't get babies out fast enough. But they're not looking at their own backyard, and they really can't get babies out fast enough there either. So when you have that catastrophic rupture, it's not necessarily, you're likely to have a bad outcome no matter where you are. But anybody who says they can't do it because they don't have 24-hour anesthesia, that's a lie. They shouldn't be doing OB at all, because like I said, 99% of emergency C-sections have nothing to do with a previous scar. I made that number up. But it's a high 90s. Okay, just so people know that I make numbers up too sometimes for emphasis.
What do you have to say about the major increase in NICU admissions in the last decade or so?
Listen, somebody's probably asking me this because they've heard me talk about this. Well, I can only the rate of I think if I remember correctly, it's either 15 or 20 years ago, the NICU admission rate was about 5.8% of babies went to the NICU. Now it's about, maybe it was 5.3. It's a little over 5. In 2023 or 2024 or 2025, it's now 9.8%. So essentially, in the last 20 years or so, the rate of NICU admissions has doubled. The question is why? Are babies and moms that much sicker in the last 20 years? And the answer is no. So there's 3 reasons I can come up with, and none of them speak well of the medical system. One is that women are sicker and babies are sicker. But isn't that the job of the maternal fetal medicine doctor and the OB, to keep you healthy? So I don't think that can be it. 2 is that maybe things that we're doing in the hospital are causing more babies to go to the NICU, like inducing everyone at 39 weeks, giving them hours and hours of Pitocin and epidurals interfering with the bonding of mom and baby and the chemical communication and the hormonal communication and all the things that go on between mom and baby, and starving a mother for 20 hours because she's in labor and she might need a C-section. So baby's, mom and baby are hypoglycemic. The baby's tracing doesn't like it. And the baby comes out with, they do an emergency C-section. And then because of the policies in the hospital, the emergency C-section babies need to be observed in the NICU or whatever else. So it's either the patients are sicker, which isn't good for it doesn't imply the medical system doing its job. 2, babies are sicker because of what the medical system is doing. Or 3, which is the most sinister of all, is that hospitals are creating policies to put babies in the NICU because the NICU is a cash cow for a hospital. Every baby that goes to the NICU, the hospital makes a lot of money on. So again, if you're the fiduciary chief financial officer of the hospital, your fiduciary duty is to make that hospital profitable. You may have your medical executive committee put in policies that say, oh, babies born to diabetics need to be observed in the NICU, which is probably the worst thing you can do for them. Any baby with an APGAR score less than 7 at 5 minutes needs to go to the NICU. Any baby over 4,000 grams or under 2,000 grams needs to go to the NICU. You start finding more reasons to put babies in the NICU. But the fact that, and these numbers, by the way, that I gave you come from the CDC. Now, I don't trust the CDC on a lot of stuff, but their data collection is their data collection. It's hard to fake that. So the fact is, it's almost doubled in 20 years. It doesn't speak well of the medical system. That's what I think about it. And I think that the idea of separating mother and baby, again, who designed NICUs? Who designs hospitals? Architects do. Architects go to architectural school to learn how to design a hospital. Why not design a NICU that has a bed in there for the mom? Have individual rooms for each baby. Baby can stay on mom's chest. If the baby needs to go to the warmer, it's right there. Mom's right with the baby. Why are we separating them? Why are we putting, 6 babies in a unit and we have 6 parents, 12 sets of parents standing in one room, but they only can be in there for like 4 hours a day because you interfere with who planned all that out? And why is the bed the center of the labor room? If anybody's ever been to a home birth, how often do you walk into a home birth when a woman in deep labor and find her laying in her bed? Almost never. Yet the person who designs labor rooms designs it so the bed's in the center of the room because that's how they think. Who goes in beds in hospitals? Sick people do. Pregnant women must be sick people. We're going to put them in a bed in the middle of their room. That's how they think.
All right, we have a question from a doula who is considering reaching out to OBs in the area to inquire about VBAC and other support. Is it reasonable to think that the OBs would meet with the doula, and how should she approach that?
Good question. I don't know your community. Some communities, it's very reasonable. Some of the doctors there are, they want to do right. It depends on the system the doctors work in. Like private doctors will probably be happy to meet with you. Doctors that work in a system where they're working shifts and stuff like that, and the policies are set by risk managers and administrators might find it a waste of time. Ideally, you should make the effort. And how do you do that? You contact the office manager and probably say, you know what, I'd like to have some time with the doctor. I'm more than happy to bring lunch for your staff if I can get 10 minutes. That's how drug reps do it. Doctors really don't want to talk to drug reps, but when they bring a nice lunch, you feel obligated to talk to them. So
At least over lunch.
that's what we did. But you should make the effort, being fully understand. But and the doctors that don't want to meet with you, you have power because you are going to have clients, and they're going to ask you questions, and you're going to say, that doctors group is not very receptive to independent thinking and doulas and alternative ideas, and so maybe you want to look for another doctor. I mean, that's how capitalism and consumerism should work. That's the problem with managed care, and people feeling stuck with their Medicaid card or their managed care card that they have to go to this particular person. Quality will always decline as things get bigger and more impersonal. So I would commend you for trying to do that. You can also go to labor and delivery and speak to the charge nurse in labor and delivery and see if there's any way that you could, come to labor and delivery and speak to nurses in labor and delivery. That sort of thing too. Get to know your community, especially if it's a small community. That might be very desirable. I know that in St. George, the hospital administrator in St. George is very receptive to the midwives and the doulas in the community in St. George, Utah. I don't live there, but I live close to there. And I know that, but it's a small town. And there's only one hospital basically that does OB there. So they're open to listening. Whereas in some bigger cities and bigger communities, I don't know what kind of reception you'll get. But you have to try. We have to try to, all the things that I told you today, that we talked about today, I would tell you that most OBs have no idea. We learn what we learn in residency. We come out, and especially when we're now just employees, and we have to take continuing education based on what the American Board of OBGYN tells us to take. There's very little intellectual curiosity in these people anymore. They don't want to learn anything new. Why would a doctor not want to know about breech delivery? Even if you can't do it, or because your policy says you can't do it, wouldn't you want to be the most skilled obstetrician you could be? And wouldn't you want to know that someday when a woman walks in and the baby's butt's sticking out, that you know exactly what to do? Instead of panicking, trying to shove the baby back inside and doing general anesthesia and doing a C-section only to pull the baby out breech anyway? I mean, is there any logic there whatsoever? No, you're only doing what you were trained to do, and you're not looking any deeper. So we need to wake them up. And some of the ways to wake them up are to challenge them. And patients need to challenge the doctors. And we need to approach them and try to do it kindly and see how that works. It can be very frustrating because they believe there's a hierarchy. And they believe what they do has authoritative knowledge over what anybody else lesser than them does. And they consider midwifery and doulas to be a lesser subset of their profession as opposed to being a completely separate profession, which is what they are. And doulas be really careful about being licensed and going and being and starting to work for hospitals and for insurance systems, because I can't warn you enough. I know that it's about making a living, and I know that there's money to be had there, but you are selling your soul. What price freedom?
Yeah, you want to think about your fiduciary duty and who that duty is to. And the next question is from a nurse. And how do we ensure that patients are truly getting fully informed consent from their providers? So for context, if we have a provider who refuses to support VBAC because we don't have enough resources in the event of a possible uterine dehiscence. Second part, how do we ensure we are using reliable resources for information? If not, ACOG or Society of Maternal Fetal Medicine, any suggestions would be great to know.
Yeah, I thought I covered the second one a little bit earlier, that it's very hard. It's very hard to know what data to use. But I mean, when ACOG guidelines do support reasonable choices and doctors ignore those anyway, that's a really good way to approach a doctor who says that, and you can really trap them. I mean, again, it's very hard to have that opportunity. It would be really nice to have an opportunity, like to have a monthly meeting of doulas, midwives, doctors, labor and delivery nurses, and have a community meeting once a month at different locations, sometimes in the hospital, sometimes in a birth center. So, and sort of have people come and share those sorts of things and break down the silos. Because so many doctors, again, they will quote things that they were taught once and never think again. And the idea that they don't have enough resources to do a VBAC is ridiculous, because what is a VBAC? A VBAC is a vaginal birth. How do you say you do not have enough resources to do that? And they'll say, well, but there's a risk of rupture. And then I've already gone over that. Right. But you also, any laboring woman could have a bradycardia. Any laboring woman could have a cord prolapse or abruption of the placenta or whatever. So you handle those people just fine. I think they actually believe what they're saying, because the alternative is unthinkable, that they actually don't believe what they're saying. They're saying it anyway. But there's a blockade there. There's a logical blockade. They don't see the logic, the illogic of what they're saying. Because every one of those doctors has done a crash C-section on somebody at that hospital, had nothing to do with VBAC, okay? And did they say, geez, we can't be doing labor here because we don't have the resources? No.
Mhm.
And if the ruptured uterus is literally, as I said, 1 in 200, 1 in 1,200 for bad outcome, but let's just say it's 1 in 200. And say your hospital is doing 5 VBACs a month. You'll have one dehiscence every 3.5 years. And for that, you're going to ban all other VBACs? Again, there's no logical thinking. Their thinking is pushed by medical legal concerns and monetary gain and expediency. It's much easier for your doctor to schedule your C-section at 7:30 in the morning on a Tuesday and be out by 8:20 than it is for him having to be available for you, even if they're working shifts, to have to deal with the anxiety and fear that they feel and project onto the woman. They're the ones that are nervous about the VBAC. The woman's not nervous about the VBAC. The woman's only as nervous about the VBAC as the doctor who's taking care of her makes her feel. Because all of us who've done birth for many years have taken care of hundreds of women with VBACs who've done great. And the success rate in the home setting is over 90%. And even when the NIH said it's 70 to 80% in the hospital. Now I know hospitals that have like a 13% success rate.
Mhm.
What the hell's going on there? But it's because they're so nervous, and you can't eat, you got to be monitored, and you can't move, and you have to, that they're setting you up for failure. So yeah, it's very difficult to deal with people that are entrenched. But as a nurse, especially a labor and delivery nurse, you bear witness a lot of times to things that must drive you crazy. I know that. I've talked to a lot of nurses. Some of my best friends were nurses at one time. They couldn't take it anymore, and they left and became midwives because they couldn't watch the abuse that went on every day, the gaslighting that went on every day in the hospital. It's really tragic. It's and I'll just say that I haven't worked in a hospital since 2010, but I worked in the hospital for 28 years prior to that. I saw everything. And I saw these kind of things happening day in and day out. I saw the skewing of informed consent. I saw women getting vaginal exams for no reason other than to update the board. As a night OB resident, when I was a second-year resident, we signed out the board at 7 in the morning. So at 6:30 in the morning, it was my job to go into all the laboring rooms. There might have been 11 or 12, 15 women laboring at Cedars, and to put on a glove and do a vag exam so I could update the board so that the oncoming chief knew what the cervical exam was of the woman in labor. Did I tell those women that this was completely unnecessary? No. I made up something that made a reason that I had to do it. So, and I did unnecessary C-sections on women. I did a lot of unnecessary episiotomies because that's what the time I was doing them, I didn't know was unnecessary. But my colleagues are still sleeping. I mean, the C-section rate when I first started in practice was in single digits. And now it's close to 35%. And our outcomes have not improved. So that means that a lot of the C-sections being done, more than half are probably unnecessary. Yet no doctor ever goes home at night saying to their spouse, hey, honey, guess what? I did a bunch of unnecessary C-sections today. They think every C-section they do is necessary, yet more than half are unnecessary. Your brain wants to explode, right? The key is for that woman to avoid that first C-section. Then we wouldn't have any reason for ICAN in the first place, but ideally.
Yeah. So here's someone that had 2 cesareans. In their second cesarean, they found a uterine window. And so now in their third pregnancy, they've been advised a repeat cesarean at 37 weeks. Data research seems to lump uterine windows together with rupture. How does this person identify their actual risk from this previous window?
Their actual risk is the same as a woman who's had 2 previous C-sections.
Yeah. So both
And
of
the
her
reason
previous pregnancies were home birth transfers. so she feels less inclined to be at home.
That's her choice. But let me just say something about the window. You go in and you find a window. Okay, great. So now you cut through the window, you deliver the baby, and what do you do next? You repair the uterus.
Mhm.
So why do you think there's going to be a window the third time? Why do you think that? Did you not repair it well?
Yeah.
I mean, do you have bad tissue? Probably not. So the idea that because you had a window in the first surgery, but then you've had surgery on that window and now had it repaired, probably in 2 layers. You could read your op report and see that. That shouldn't matter anyway. But some doctors, like, they look for reasons not to do VBAC, so they'll find like you need a 2-layer closure. We could talk. That's another topic for another day. The VBAC calculators are a total waste of time. They don't mean anything, and the doctors will use them. Doctors who don't want to do VBAC will use them. Doctors who are supportive of VBAC don't really care about those sorts of things. So, but the idea that because you had a window and they went through it and then it sewed it back up doesn't mean you're going to have a window the next time. So you have the same risk as somebody who's had 2 previous cesarean sections and having a VBAC, which I come up with a number based on my experience of about, instead of 1 in 200, about 1 in 150. And you still have the 5 to 20%, 5 to 16% risk. So 1 in 150 times 1 in 6 is 1 in 900. So your risk of having a really bad outcome with a VBAC after 2 is probably 1 in 600 to 1 in 900. And that should be a woman's choice, very reasonable choice to choose to have a VBAC after 2 C-sections. My success rate in my practice, again, anecdotal, was 100% with VBAC after 2. I never had someone, I didn't have that many. I probably had maybe 20 that I can recall in my charting. Because I didn't, when I was a young doctor in the first 10, 15 years in practice, I didn't keep track of my statistics. Doctors generally don't do that. Only when I started working with midwives did I start keeping track of my statistics, because midwives taught me that. So, right. I hope that answered that question. I don't think that you should do that, but you need to find someone who's supportive of that. If you're going in with somebody who's constantly harassing you or wants to measure your scar thickness on ultrasound to give you another reason why you shouldn't labor, that is not somebody that you should go, because they're not VBAC friendly.
So we have another question. What literature or online educational programs would you consider worth mentioning for those that want to learn more about birth and have better decision making, besides what you are offering? And kind of along with that, what is the solution to these issues? Is there anything that we can do to solve the
Wait, what was the
ongoing
last
problem?
sentence? What was the last sentence?
Oh, but and then in addition to that is there anything we can do to solve these ongoing issues?
Wow. Okay. It's not going to happen overnight. A very good resource for VBAC stuff, you guys all know them already, is Jen Campbell's VBAC Facts. I think she does a really good job with the data on VBAC, and she keeps up on anything new. I'm not sure there's a lot of new research on VBAC lately. I haven't seen much, but she keeps up on anything new. So VBACfacts.com, I think, is a good place to get your information. Again, if you don't want any information, I have very mixed emotions about AI. Like, sometimes I will ask Grok or ChatGPT a question and they'll give me a sort of a standard answer. And then, because I know more than the standard doctor knows, I start to say something, but isn't it possible that this was, and they go, you're right. This is, breech birth is blah, blah, blah. So getting your information from AI, again, is basically garbage in, garbage out. It depends who's programming it and what they're searching. And again, if you look at the way Google puts its searches up, they tend to put up the things that are mainstream first, things by ACOG or whatever, and they're not going to put up a paper by, well, unless you specifically put the title in, you're not going to find papers by me or Rick Safries or things like that as far as data goes. Solving the issue is essentially individual family by individual family for now, and making demands on what we talked about in the PowerPoint presentation. having your right of informed consent. And because the way the system is, most doctors, again, are employees now working a shift and working volume. Doctors, unfortunately, and I feel bad for them, but it's kind of a bed of their own making, is they don't have the time to offer you the information you deserve. It's a bit disrespectful, but they don't have the time because they should be able to sit down with you. Listen, in midwifery model of care that midwives taught me, my prenatal visits were an hour long. But I didn't take insurance. I charged what I thought was fair. People paid it or they didn't. And again, that was some people could not afford me. And I understand that that's not fair, but that's the way it works. But I could give them the information. And by the time we got to the end of their pregnancy, the visits were more about, how's life and how are the kids and this, because we really covered everything already and we knew each other really well. And so the confidence level was very high. When you go into the care the way it is right now with the medical system, you may love your doctor, but your doctor's in a group of 7 people. So when you go into labor, you got a 1 in 7 chance, unless you choose to be induced on the day your doctor's on call, and then you're meddling that's a whole nother mess. So the system is completely broken for those of us in it. It's working really well for those that manage the system. They're very happy with it because they can control all the widgets. Patients, it's really interesting. Patients used to belong to the doctor. And the doctor brought his patients to a hospital. And if that hospital wasn't nice to that doctor, a little bit of an ego thing going on there. But if it wasn't nice, that doctor would say, okay, I'm taking my patients over to Methodists and we're leaving from here. Well, hospital business managers thought that that's not a really good business model. So eventually they figured out managed care and they basically took over the patient lives and they began hiring the doctors. So now if a doctor works too slowly or a doctor says things they don't like, they fire the doctor instead of the doctor firing the hospital. It's a mess. And they're not going to let go of that system. It's not like suddenly they're going to realize that our system isn't working, our outcomes are bad, they're getting worse. So we're sorry, we're leaving. No, they're not going to do that. So each individual family needs to take control of their own destiny and their sovereignty, and that helps by having a health savings account and doing your homework. Do as much homework for this as you do when you buy a home or when you're planning your wedding. This is what you have to do.
All right.
We out of time?
I think we'll just do one more question, if that's all right.
Okay.
So is a woman who conceived in the 4th month after postpartum or 4th month postpartum after giving birth through surgery a good candidate for physiological birth or not?
So a woman has a 4-month interval between the C-section that she had and her conception.
Yes.
Okay. The data on interpregnancy interval is what that's called, is not great. But it does seem that when the interval is less than 6 months, there is a higher rate of scar dehiscence. What the higher rate is, I can't rattle off the top of my head for this webinar right now. I don't know. But you could look into that. You could try to figure out what the numbers are. A lot of doctors will say you need to wait 18 months or 24 months. And if you're less than 18 months, like you're 17 months and 3 weeks, then you're not a candidate for a VBAC. Anybody that's that rigid is, the whole idea that you're 34 years old and you're fine and you're 35 and you're high risk, or your diabetes screening, you're 139, you're normal, you're 140, you're abnormal. Those exact numbers, I have this aversion to those exact numbers. The whole idea of 24 hours of ruptured membranes or 42 weeks or any of those things, they're kind of all made up numbers. But the 6-month interval is also a made up number. But a shorter interval, like 4 months, there is probably a greater risk because healing does take maybe up to 6 months. So counseling should include that information, but higher chance of something bad happening doesn't mean it's high risk. And so each individual woman needs to make that decision for herself. Does she want a 3rd baby? Does she want a 4th baby? Because if you want a 3rd baby, then maybe you want to avoid that 2nd C-section. Because with every C-section you have, you increase your risk of future problems, including rupture and or abnormal placentation, which is something like placenta accreta. So you have to weigh those risks. And that's where that ACOG thing that says counseling should be taken in context of a woman's lifetime values, concerns, as opposed to just giving a one-size-fits-all recommendation. But again, the medical system doesn't like variability. They like one-size-fits-all. So all twins need to be delivered at 36 weeks or 37 weeks or whatever, you know, or nobody can go past 40 weeks or 41 weeks or whatever. I mean, that's ridiculous. But big systems have hard time individualizing care, which is why little systems are better. But little systems don't make businessmen a lot of money.
Mhm.
Big systems make businessmen a lot of money. And everything that we do, and every invention or intervention or technology or guideline that they put in is about increasing revenue. They'll dress it up in the guise of safety. The welfare of humanity is always the alibi of tyrants, said Albert Camus, and he's right. They'll always dress these things up in the guise of safety. But it's not necessarily safer what they're recommending. These things, the whole system has made outcomes, despite all these interventions, as I said earlier, our outcomes are not better. So we need to let women decide, again, based on the best information possible. But again, they also have the right to say, I don't care about that information. I want to have this, I want to take the risk. Now, as a woman who makes that decision, though, you've got to stick with your risk. If you make a choice and the outcome is bad, stop blaming the doctor. Stop blaming your hospital. Stop blaming the system. If you want to take responsibility, if you want to make your own decisions, you have to take responsibility for them. Right? It works both ways. I'll just leave it at that.
Thank you very much, Dr. Stu. I'm going to read your bio once more. Stuart James Fischbein, MD, is a community-based obstetrician and associate of the American College of Obstetrics and Gynecology, published author of the book, Fearless Pregnancy, Wisdom and Reassurance from a Doctor, a Midwife and a Mom, and peer-reviewed papers, Home Birth with an Obstetrician, a series of 135 out-of-hospital births, breech birth at home, outcomes of 60 breech and 109 cephalic planned home and birth center births, and twin home birth, outcomes of 100 sets of twins in the care of a single practitioner. After completing his residency at Cedars-Sinai Medical Center in Los Angeles, California, Dr. Stu, as he is known, spent 24 years assisting women with hospital birthing and, for the next 12 plus years, was a home birth obstetrician who worked directly with midwives, assisting local Southern California families. Since retiring from attending home births in late 2022, Dr. Stu has turned his focus to traveling around the world as a lecturer and advocate for reteaching breech and twin birth skills, respect for the normalcy of birth, and honoring informed consent. He hosts the weekly Birthing Instincts podcast with co-host Bliss Young, and together they offer hope, reassurance, and safe, honest, evidence-supported choices for those women who understand pregnancy is a normal bodily function not to be feared. Follow him on Instagram at Birthing Instincts. He can be reached via the websites www.birthinginstincts.com and www.birthinginstinctspodcast.com.
Yeah, everything is birthing instincts.
Yeah.
Yeah. Hey, listen, thank you for that. Thank you for the opportunity to speak to you all. Thank you for the great questions and the attention of all these people that were online and the people who are going to watch it later. I just want to say my thoughts go out to one of your members, and I'll just leave it at that. I don't know if is any public knowledge yet, but praying and I'm hurting.
Thank you so much.
Okay. Bye, everybody.
All right. Thanks. Have a good night.